Hello, my name is Jeanette Gogan and I'm the Program Director of Internal Medicine at U of T. I would like to spend the next 12 minutes or so providing an overview of competence-based medical education, or competence by design as the Royal College calls it, from the internal medicine perspective. CBME is an educational model that is more oriented to outcomes rather than time and training, i.e. what a trainee can do, more flexible to learners' prior skills and current needs, training using a coaching approach with more regular feedback and entrustment decisions, enhanced tracking of learners' progress and performance. The idea is this will take us to the next level with respect to coaching and tracking. It's currently used in the US and many European countries, and in Canada in family medicine. CBD, or Competence by Design, is the Royal College version of CBME. It is philosophically driven, formalizing and implementing what we have already been doing. Now we're moving, though, from objectives to outcomes. It involves the key direct observation, feedback, and coaching steps. This will hopefully allow for earlier identification and help for trainees in difficulty and de-emphasize time-based learning. There's an emphasis on teaching, feedback, coaching, all as part of assessment. The evidence for this is growing, and this is an important contribution that U of T can make. Royal College is rolling out CBD for approximately 80 specialties in 7 cohorts over the next decade. The U of T internal medicine pilot started August 1, 2017. Phase 2 pilot starts July 1, 2018, with more EPAs being assessed, academic advisors in place, and the competence committee in place. Full implementation is scheduled for July 1, 2019. The big picture for internal medicine involves stages of training, curriculum design with longitudinal coaching, EPAs amongst other assessments, where each EPA assessment is one small piece of the puzzle giving formative feedback. The academic advisors examine the assessment data, coach the resident, report to the competence committee, and finally the competence committee puts the pieces of the puzzle together. The stages of competency on the CBD competence continuum start with transition to discipline in the first 4 blocks of residency, when the trainee learns how to manage their new role as a resident. Foundations of discipline follows for the rest of the PGY 1 year. The resident subsequently enters core of discipline for the PGY 2 and 3 years, and finally the PGY 4 year is spent in transition to practice, when the trainee practices the skills they will require to work as an independent internist when the training has been completed. We've been talking about EPA. What is an EPA? It's an entrustable professional activity. It's a unit of work actually done during a clinician's day, such as admit a patient to hospital, carry out a procedure, or lead a family meeting. There are 29 EPAs for the PGY 1 to 4 internal medicine training program. Each EPA gets assessed several times for each resident. Each EPA is made up of several elements or milestones, and the EPAs increase in complexity throughout the stages. Resident assessment, this is how it will work. Clinical supervisors provide assessments on an electronic platform called MedSquares in the workplace for most of the EPAs. EPAs map to a resident and rotation for each rotation of the year starting July 2018. 1 to 2 EPA assessment completions per trainee per week will be ideal. There'll be notification by email to the residents and to the rotation coordinator each month. The EPA assessments are structured to take only 5 to 10 extra minutes and to fit into the workflow. For instance, performing history and physical exams, documenting and presenting findings across clinical settings for initial and subsequent care, part of transition to discipline. Assessing, diagnosing, and initial management for patients with common acute medical presentations in acute care setting is part of foundations of discipline when they're actually managing the problem. For core of discipline, they are managing complex or atypical acute medical presentations. As you see, as you go up the stages, the EPAs get more difficult. Let's talk about the basic structure of EPA tools. There'll be the demographics, which you or the resident can fill in. The elements or milestones, at least 3 should be completed with comments. They don't all have to be completed though. You will make a global entrustment decision and global comments with next steps or actions. Let's look at the overall entrustment for this EPA for this event at this time. If we go to the very bottom of the scale, intervention, someone else had to complete all or most of the activity. For direction, it required major instruction. Support still required some minor advice. These are all not considered entrustment. For actual entrustment requires autonomy, i.e. the supervisor didn't need to be there, or excellence, demonstrated leading practice, acted as a role model. Steps to completing an EPA form. First, preceptor and the resident initiate the assessment. Preceptor should plan the timing of assessments at the start of the supervising block. 2, the resident presents the case or conducts the activity, and the preceptor directly observes some component, for instance, verifying the history and physical findings. 3, the resident or preceptor opens the EPA on an electronic platform on the phone or computer, best to use Chrome, and enters the demographics. 4, preceptor chooses 2 to 3 milestones or elements to provide comments on and ranks the elements on the scale. Then the preceptor provides the global entrustment score with overall comments and recommended next step and discusses the feedback with the resident. Current EPAs are for transition to discipline, that's the first stage, first 4 blocks of PGY1, performing the history physical, assessing unstable patients, and performing the basic procedures of internal medicine. This third one for basic procedures will be done in the simulation lab. Foundation of Discipline EPAs cover blocks 5 to 13 of the PGY1 year. The first is managing straightforward chronic diseases. The second is the initial management for acute care. The third, ongoing management of acute care. Then consulting specialists and other healthcare professionals. Discharge plans, treatment for unstable patients, goals of care, identifying and addressing personal learning needs, and finally, for the full 3 years of core medicine, performing the procedures of internal medicine. Core of discipline for the PGY2s and 3s, they will only be doing 4 EPAs, assessing, diagnosing, and managing patients with complex or atypical acute medical presentations, assessing, diagnosing, and managing patients with complex chronic diseases, assessing, resuscitating, and managing unstable and critically ill patients, and performing the procedures of internal medicine. PGY 1s, 2s, and 3s are all expected to be getting at least 1 EPA done each week. Resident assessment, how it will work. Many residents are not initially entrustable for an EPA. This is normal and expected. It may take several observations with feedback and coaching to become entrusted for an EPA. The EPA global decisions are not averaged over time. Once the resident achieves the required number of entrusted assessments at autonomy or excellent levels, they will be considered entrustable for that EPA. Multiple observations are collected and collated for each resident using learning analytics. Other assessment instruments will still continue. The ITAR's in-training assessment report are like ITARs and will eventually replace the ITARs to provide a global picture of the resident for the entire rotation. The in-program OSCE exams and the in-program ACP written multiple choice question exams will still continue as well. Finally, the academic advisors will each be assigned up to 5 residents to provide mentorship and longitudinal coaching for them. The Competence Committee meets 4 times per year for each PGY cohort. It's made up of site directors, remediation lead, program director, and 1 resident, a PGY 5 in GIM or a medical subspecialty. It receives all the data on the resident and reports from academic advisors. It decides on the overall entrustment of a resident for each EPA based on multiple assessments received. This means each EPA assessment will have a very small impact. It decides on overall promotion for a resident and monitors interim progress. Finally, it formulates any needed remediation in collaboration with academic advisors and remediation experts. Here are some teaching and implementation tips for supervisors completing EPAs. Our goal is to minimize the impact on your clinical efficiency and flow while maximizing the benefits to our trainees. Observations can be direct or indirect, complete, which is probably going to be very rare, or partial, and most should represent 5 to 10 minutes of additional time. Most observations can occur during traditional case review, which includes going to meet the patient with the trainee. For example, at the bedside with the trainee, one could ask them to do one of the following per observation. Ask them to obtain clarifying history and observe them, do that. Ask them to demonstrate a physical finding and observe. Ask them to outline investigations or management plan to the patient and observe their communication skills. Then provide 3 brief points of feedback based on your observation and document it electronically. It's important to assess them at their current level of training. If you're someone who has difficulty giving residents feedback, try telling them that you'll be providing feedback to get them to the level of a Royal College internist, as residents don't expect to be at that level and are quite eager to achieve this. Plan strategically, have login and password to access the EPA website, cbme.usquaresoft.com. Have a place to give the feedback. Consider bookmarking the website on your computer. Make a contract with the resident about EPA type and timing. Look ahead across the whole week and consider the less busy days. Perhaps morning post-call case review. At the very end of daily work rounds, do one observation with one trainee during a necessary patient visit, for instance, at an immediate pre-discharge visit or a post-discharge clinic follow-up visit. These are the instructions to get set up on cbme.usquaresoft.com. You can follow the instructions you receive from the postgrad office email sent every June or July of each year, or otherwise you can follow these instructions on your own. So in conclusion, CBD is an exciting opportunity for our program. It is important to directly observe residents, provide honest, actionable feedback, make an entrustment decision, and record the encounter. Please let us know if you have any feedback on the CBD process.